Hi guys, welcome back. Next up is mixed disorders with respect to ABG. I'm going to describe you cases where person could be having two types of acidosis, metabolic and respiratory acidosis coexisting, or patient could be having metabolic acidosis with metabolic alkalosis. When I say that, lots of time, students interrupt me while I'm taking a live class and they say, "Are you serious, sir? I mean, a patient could be having combination of metabolic acidosis with metabolic alkalosis. I mean, is it really, really possible?" So yes, guys, I'm gonna prove it to you mathematically, and not only mathematically, I'm gonna give you real case scenarios where these combinations would be possible. So lots of interesting stuff lined up in this video. And if you come to this one directly, my suggestion would be to listen to part one and part two so that this makes more sense to you. Having said that, let's focus on a question that was asked in recent NEET PG as well. The ABG of the patient was 7.3, so I know there is an acidosis present, normally 7.35 to 7.45, and there can be two reasons for development of acidosis. One is a respiratory problem or there can be a metabolic problem. In respiratory problem, the PCO2 has to be elevated more than 45. In this question, you can see it is 30, that is even lesser than normal. So first my deduction is this cannot be a respiratory problem. So I am left with only one possibility, that is the primary problem of this patient is metabolic acidosis. Having said that, because bicarbonate is lesser, normal bicarbonate is 22 to 26 millicoulomb, here it is lesser, so the interpretation of metabolic acidosis seems very logical. Now my job would be to determine whether person is having compensation or not, because compensation implies that every time there is acidosis, metabolic at the moment, the protons in the body are going to stimulate the respiratory center and the person is going to hyperventilate, and hyperventilation will cause a carbon dioxide washout. So far so good, because carbon dioxide is lesser, so it looks like okay, this is going to be a compensation working, but we need to prove it mathematically. Now for mathematical proving, you need to use what is called as Winter's formula. The moment I said this, I know your mind is racing for that simple calculation that I'm going to tell you. This would be 1.5 times whatever the value bicarbonate is given in the question. Like in this case, it is given to be 10. And to this, you need to add then 8. And from that, you need to subtract plus minus 2. So mathematically, I can say this would be 15 to 10. That would be 1.5 into 10. That is 15 plus 8, 23 plus minus 2. I am gonna also teach you a simplified version of Winter's formula, which is called as modified Winter's formula. And in modified Winter's formula, it is a one-step addition. You see, because there is paucity of time always in the exam. So if you're comfortable with first doing multiplication and then doing addition, and from that you doing plus minus 2, I'm okay with it. Otherwise, I'm giving you a much more simpler solution or a hack, which is whatever is the bicarbonate given in a question, to that add 15. Like in this particular question, we are adding 10 to 15 to generate a mathematical value 25. And what is this 25 that we have generated? This that we have generated is called as expected PCO2. So Winter's formula is used to determine expected PCO2 and compare it with now the actual PCO2 of this case. You can see that when you're gonna do this matching activity, the actual PCO2 is 30 and the expected PCO2 calculated from the formula is 25, which means that because both values are not matching, therefore it cannot be a compensatory disorder. I repeat my statement once again. How do you determine whether the person is having a compensation in metabolic acidosis or is the person having a mixed disorder? You need to deploy Winter's formula or modified Winter's formula. Whatever you calculate from Winter's formula or modified Winter's formula, if that mathematical value matches with the actual PCO2 given in the question, like suppose in this question, the actual PCO2 was also 25 millimeter of mercury, I would have said it is compensation and I would have marked option number B as the correct answer, that is metabolic acidosis with hyperventilation leading to respiratory alkalosis. Makes sense. But because mathematics is telling me otherwise, the answer to this question cannot be B. Now let's focus on A, metabolic acidosis with hypoventilation. When I specifically focus on hypoventilation part, the query of a lot of people is, sir, are you kidding me? I mean, hypoventilation should be causing carbon dioxide value to be more than 45 millimeter of mercury. Here it is 30. How can you say it is hypoventilation? So now listen to my next statement. Suppose a patient of diarrhea is also having hypokalemia. Diarrhea will cause metabolic acidosis, understandable, because there is underperfusion of tissue, so metabolic acidosis. Because there is a coexistent hypokalemia, do you think his diaphragm will be able to work like it should be? No, now, because hypokalemia causes diaphragmatic paralysis or diaphragmatic weakness. So a diarrhea patient without hypokalemia will be able to do proper compensation. But if a diarrhea patient is having severe hypokalemia and his diaphragm is not working, then his diaphragm will not be able to clear the carbon dioxide down to 25, and the carbon dioxide of the patient is little higher than normal. Therefore, because the actual PCO2 in this case is more than the expected PCO2, therefore the interpretation is mixed disorder. What you learned at the moment is that in every MCQ metabolic acidosis that you deal with in your career, you need to compare the actual PCO2 from the expected PCO2 that you generate from the Winter's formula. If matching is there, you will say compensation. But suppose like what is happening in this case is that the expected PCO2 is higher than the expected PCO2, then you will say, no man, there is no compensation. What is present is a mixed disorder. And this hypoventilation, the term that I've underlined, is in a relative sense. You see 25 versus 30. That means hypoventilation is present because carbon dioxide has to go down to 25 for compensation, because it did not go down to that level. Listen to the words again carefully. Because carbon dioxide did not fall to that value of 25, there is a relative hypoventilation, and this relative hypoventilation means this extra carbon dioxide which is still present will generate carbonic acid. Carbonic acid is acidic, so there is a respiratory acidosis in this case. The correct answer to the first question in this video is option number A. And let's also rule out option number C. Respiratory acidosis can immediately be ruled out, because for respiratory acidosis as a primary problem, PCO2 should be more than 45 millimeter of mercury. And in this question, the PCO2 was already lesser than normal. The answer to this question cannot be D, respiratory alkalosis. So I'm very sure the moment all of you read this question, C and D would not have been a problem. D because pH is acidic, it's not alkalotic pH. So C and D everybody could rule out. But in the actual exam, a lot of guys worked out it is metabolic acidosis and assumed that because it's gonna be a compensation which is present. I mean, obviously compensation should be there. But because this person could be having a second problem in his body, by second problem, like I gave an example of hypovolemia, no big deal that this guy's body could not compensate. So if you're having more than one pathology in the body, mixed disorders can come in, and therefore I've given you mathematical version of metabolic acidosis and respiratory acidosis. What is the mathematical version? You need to remember that the actual PCO2 value which will be given in the question will be higher than the expected PCO2 value that you calculate, and the minimum message is that for every question of metabolic acidosis, just add 15 to the value bicarbonate and subconsciously look at the PCO2 value that you have calculated in your mind versus the actual that is given. If they're matching, cool, it is compensation. Because they're not matching, therefore since it is higher, there's a hypoventilation and a respiratory acidosis. Now I'm gonna prove it to you in a real case-based scenario also. So it's not that, as I said in the beginning, it's not only mathematics. I'm gonna prove it to you. How is that happening? We have a 40-year-old man who presented with flash pulmonary edema. Though flash pulmonary edema is itself a one-liner MCQ and the answer from the four options would be very clear, but let me read out the question before you for formality. Glucose is 243. I mean, in Indian patients at 40 years of age, no diagnosis of type 2 diabetes is no big wonder. So, I mean, 243 is in a diabetic range. Blood urea is ultra high. I mean, the kidney of this guy is failing. That is, creatinine is up to 1.2. Here it is 1.5. Blood urea is up to 45. Here it's going up to 81. So, there are two things which are happening in this patient at the moment. One, he's having pulmonary edema, which means heart failure. I mean, every time you read pulmonary edema, you know there is a heart failure. And second, what you're noticing is that the person is also having a kidney injury. It could be acute kidney injury, it could be chronic. I cannot pick it up because since he's mentioned elevated blood glucose, it could be a diabetic nephropathy which has resulted like this. So it could be acute or chronic kidney disease. But ultimately, the deductions are that this person is having heart failure at the moment as well as a kidney involvement. He is himself mentioned ABG shows respiratory acidosis and metabolic acidosis. I'll give more explanation for this line in few seconds from now. He says, what is the possible cause? Option A says autosomal recessive polycystic kidney. Autosomal recessive is a pediatric presentation. This is seen in children. So that is why my case is 40 years of age. So unlikely as an answer. Autosomal dominant tubulointerstitial kidney disorder. I mean, this particular disorder is not to be mixed with AD-PKD. This is AD-TKD, that is T for tiger, tubulointerstitial kidney disease. This disease contributes to end-stage renal disease. This is okay. But then this is a disease of the tubules because of which uric acid excretion from the body is hampered. And people with autosomal dominant tubulointerstitial kidney disease tend to develop uric acid stones. I would suggest you to go through ciliopathy's video in the renal section where I've taken care of AD, TKD, and there I've also explained the ESRD component and renal failure component in uric acid stones. Since no mention of any uric acid stones and there is no information also with respect to tubular damage, so I'm keeping it as an unlikely possibility. I'm left between renal vein stenosis and renal artery stenosis, renal vein thrombosis and renal artery stenosis. Renal vein thrombosis usually presents with unilaterally enlarged kidney, because on whichever side the renal vein will be thrombosed, the blood will continue to go via the artery into the kidney, but it will not be able to come out because there's a thrombus in the renal vein. So there is a stretching of the kidney parenchyma, the stretching of the capsule of the kidney. On an ultrasound in renal vein thrombosis, we always have unilaterally enlarged kidney. Subsequently, we might have to do a MRI or MRV, magnetic resonance venography, or a MRI, and we are able to pick up a clot. But the point is that renal vein thrombosis should be having this finding, which is not given. And as I said, I mean, though I made it a little longer for you, right? The first line of the MCQ will make it easier for you to comprehend that flash pulmonary edema is a feature of renal artery stenosis. Now, let's work out the theoretical part. You see, what I'm saying is because the person is having pulmonary edema, there is left ventricular failure. Every time you have left ventricular failure, the cardiac output will be less. If cardiac output would be less, the blood supply to the kidney will also be less. And therefore, if you are having decrease in renal perfusion, therefore, there can be possibility of renal failure as well, which explains the fact that why in this particular case was there elevated urea and elevated creatinine. If the kidney will fail, kidney will not be able to excrete hydrogen, and therefore there will be a development of metabolic acidosis. So the metabolic acidosis component can be explained by the involvement of the kidney and the low cardiac output from the heart. The second problem in this chap is pulmonary edema component. There is fluid in the alveoli, and imagine there is fluid in the alveoli, then can carbon dioxide be excreted properly from the body? No. And if carbon dioxide cannot be excreted, carbon dioxide will rise in the body. It will combine with water to form carbonic acid, and because carbonic acid is acidic in nature, it's going to contribute to development of respiratory. I'm saying respiratory because patient is having pulmonary edema problem in lungs, and because carbon dioxide cannot be excreted, person is having respiratory acidosis. So I've also given you a case scenario where you could be having two types of acidosis existing in a single patient. Your single one-line answer to where do you get combination of metabolic acidosis and respiratory acidosis at the moment would be congestive heart failure. You don't even need to remember the aspect related to kidney, because if there is congestive heart failure, the output to kidney will anyway be hampered. You know, you always read the word cardiorenal syndrome. So if heart is affected, kidney blood supply, kidney perfusion would be affected. If kidneys are damaged, you always have a metabolic acidosis. And if the lungs are going to be having a lining of fluid inside, there's a pink frothy sputum, the person will not be, there will obviously be respiratory failure. There's going to be hypoxia. But more importantly, because this person is not going to be able to excrete carbon dioxide, that is why we can have a combination of two types of acidosis, and the ABG report of this patient would be identical to what we discussed in question number 1. So in the earlier videos, I've given extreme situation, combination of metabolic acidosis and respiratory acidosis with cardiorespiratory arrest. Like, you know, if somebody is in cardiorespiratory arrest, if his heart is not beating, cardiorespiratory arrest both present. If heart is not beating, low cardiac output, so there is cells getting less perfusion, and therefore lactic acid will be generated in tissues, and therefore there is metabolic acidosis. And if person is in respiratory arrest, will he be able to breathe? No, carbon dioxide will rise and will contribute to development of combination of metabolic and respiratory acidosis. So at the moment I can say that apart from heart failure, another scenario where I have proven to you verbally, though this is discussed in theory in the earlier part of the video as well, would be cardiorespiratory arrest. I repeat my statement. Two examples of where you can be having simultaneous presence of metabolic and respiratory acidosis, or two examples where you could be having a ABG report, which has been discussed in question number 1, is left ventricular failure, or like left ventricular failure due to any reason. It could be beriberi, it could be anemia, it could be COVID-19 myocarditis, but then there would be combination of two types of acidosis, and to work it out, you'll have to use this mathematics that I've explained, and every time you will deduce this basic data, the actual PCO2 value will turn out to be higher as compared to what was expected, and that is in a relative sense that there is a hypoventilation occurring in this case. So I've given the justification for the hypoventilation word once again. again, don't try to solve this question by English. English would tell you hypoventilation matlab carbon dioxide elevated. No, it is in a relative sense. The carbon dioxide values for this case are relatively elevated as compared to what should be the expected PCO2 based on the modified / Winters formula. Coming to the next question, which was line to line repeated from Harrison and asked in the INISET exam, he said CKD patient with type 2 diabetes. Type 2 is usually diabetic nephropathy contributing to CKD, presents with vomiting and the following ABG report. And he's on empagliflozin, thiazides, ramipril, bedtime glargine for better glycemic control, so standard medication. And when you look out the pH of this patient, you are noticing that pH is normal. PCO2 is 35 to 45, it is normal. Bicarbonate is 22 to 26, it is normal, and you're wondering to yourself what's going on, man, because everything is looking normal. The first thought process of mine is I should answer this as a normal report, but then my sixth sense as a doctor told me that I also need to calculate anion gap. Anion gap is difference between positive charges and negative charges. So all you need to do in this question is take the positive charges as sodium, neglect potassium, even if it is given in the question like in this case, and the negative charges are chloride and bicarbonate, and let's do a bit of mathematics. From 140, I need to subtract, that would be value of chloride and bicarbonate. And when I'll do this mathematically, this would be 140 minus 113. The value will turn out to be 27, which is much more excess of normal, because normal anion gap would be up to a value of 12. But in this case, you can see anion gap is elevated. So first and foremost, my interpretation is that this guy is having a high anion gap. And this is the warning sign for me that this ABG could be falsely normal. I repeat that again. The moment I see anion gap is much higher, at almost more than double of normal, it tells me this ABG report can be falsely normal. The moment I see this, now there are two approaches for me. Approach number one will be I can go clinically. By clinically, I mean that because person is having kidney disease, every time kidney parenchyma is affected, kidney will not be able to excrete hydrogen. If it cannot excrete hydrogen, it will cause metabolic acidosis. So metabolic acidosis is always a feature of any tubular disorder of the kidney, parenchymal disorder of the kidney, vascular cause. I mean, every time kidney is involved, we always get metabolic acidosis. Now, there's another problem in this guy. He's also puking. The reason for that would be that if blood urea nitrogen and creatinine become very high, especially when uremia sets in, it can cause irritation of stomach mucosa and cause vomiting. Vomiting, you are aware from the previous discussions, causes metabolic alkalosis, and therefore this metabolic acidosis and metabolic alkalosis will cancel each other, and therefore pH is turning out to be falsely normal. The report of this patient is falsely normal. I'm ruling out option number C. The report is falsely normal. Why? Because there are two different disorders occurring in the body of this patient, metabolic acidosis also, metabolic alkalosis also, and both of them are going in opposite direction. It's like a tug of war. Ek acidosis kara raha hai, ek alkalosis. In that tug of war, the pH will remain static. That would be normal. And another hint which is given in this question towards metabolic alkalosis is thiazides also. You would be aware from your knowledge of pharmacology that thiazides cause hypokalemia, hypomagnesemia, and the third thing every pharmacologist is going to tell you that thiazides contribute to metabolic alkalosis. So that is way one to solve this question, that okay, clinically speaking, he's having a high anion gap metabolic acidosis with metabolic alkalosis, which narrow down to option number A as an answer. I'll now give you a mathematical version of the same. The mathematical version is that he says that every time you are gonna evaluate a high anion gap in a setting of normal ABG report, you should also do a calculation that is called as delta ratio. If the delta ratio value will turn out to be more than 2, it means that person is having a combination of metabolic acidosis and metabolic alkalosis. This has been determined mathematically. The delta ratio value more than 2 is combination of metabolic acidosis and metabolic alkalosis. Now, what is delta ratio? Delta ratio basically means that in the numerator, you need to take the change in the anion gap, and in the denominator, you need to take into consideration the change in the bicarbonate value. So let me just do this. I mean, in the numerator, I need to put in the value of the anion gap that I have calculated. CALC means whatever is the calculated value, which is 27. And from this, I need to subtract 10. 10 is an average value for anion gap. I've taken average value is 10. In the denominator, it is 25. We can take 26 also, because bicarbonate is actually a range. So I'm taking 25. And from that, I need to basically subtract whatever is the bicarbonate value given in the question. So let's do a bit of mathematics here. Anion gap in this case calculated is 27. From that I'm subtracting 10. That would be a mathematical value of 17. In the denominator, what I need to do is 25 minus, that was the average bicarbonate value. From that, I have to subtract what was the actual bicarbonate value given in the question, which was 23. And you can see that this will turn out to be something like 17 divided by 2. And since the mathematical value will be something in the range of about approximately 8, so this is much higher than the threshold I was telling you for delta ratio of 2, and therefore the diagnosis is once again high anion gap metabolic acidosis with metabolic alkalosis. I'll give you a proof of this also. This is what the textbook says, that every time you are gonna generate what is called as delta ratio. Delta ratio is in the numerator, you take into consideration the change in the anion gap, the fluctuation in the anion gap that is happening. In the denominator, the change in the value of bicarbonate, and then once you generate this mathematical value, in case the value turns out to be more than 2, it's a combination of metabolic acidosis with metabolic alkalosis. I'll show you another algorithm from a textbook which says like this, that especially in those cases where you are having an anion gap which is elevated, what you need to do is check out the change in the anion gap and change in the bicarbonate. In case you get that the change in the anion gap was 27 and the change in the bicarbonate was only 2, if the value is like a change in anion gap is more than the change in the bicarbonate, it means person is having a metabolic acidosis plus metabolic alkalosis. If the reverse was happening, then you will say person is having a combination of high anion gap as well as normal anion gap. Another point I just told you as a matter of fact, pure mathematics from ABG perspective. And this particular section, this particular video has mainly been created in this particular section or in this particular version of the app, mainly to handle these mathematical versions which were not handled in the previous two videos, which is that if the change in the anion gap is much higher as compared to bicarb, you don't, here it's even simpler. No, there's no need for any division also. Just check out the change in anion gap, change in the bicarb values. If it is higher, you say combination of metabolic acidosis and metabolic alkalosis. If it is reversed, then you say it's a combination of HAGMA plus NAGMA. Coming back to the answer to this question, it is option number A. Option number B was saying NAGMA. So NAGMA was ruled out anyway because the anion gap values were much more elevated. And then D says pure anion gap metabolic acidosis. He just says high anion gap metabolic acidosis. This is a combination of high anion gap metabolic acidosis with alkalosis. And if you don't want to get into mathematics, in my personal opinion, this is more than sufficient to solve it. And this is the only situation, this is line to line picked up from a table in Harrison, which is that if you are having a combination of CKD with uremia, CKD will cause uremia, and that, not all CKD patients will go into uremia. No, if it's going to be early part, then you won't have a uremia. But once a CKD patient deteriorates into uremia, his pH can be falsely normal because traditionally damage to kidney always causes metabolic acidosis. But once there is repeated vomiting episodes, the two, like I said, tug of war. One is acidosis, second is alkalosis. Both are against each other, so both of them are pulling, and therefore the center point remains stable, and that is the explanation for why the ABG report of this patient was turning out to be falsely normal. The giveaway in the question was elevated anion gap. Coming to the next question, which has been designed to keep a pressure off from all the mathematics that we were talking. So let's focus on logic now. He says, which of the following will differentiate acute from chronic respiratory acidosis in assessment of a GBS patient? Because Guillain-Barré syndrome will cause paralysis of diaphragm, and therefore initially person will be having, in the first day of illness, it would be an acute onset respiratory acidosis, because every time there is a diaphragm paralysis, carbon dioxide will begin to rise. So every time it's going to be acute respiratory acidosis, you will find that for every 10-point increase in the value of carbon dioxide, like suppose carbon dioxide average is 40, when it will increase from 40 to 50, the bicarbonate value will increase by 1 milliequivalent. This I've explained in the previous video also, the rule of 10:1 for respiratory acidosis, that for every 10-point increase in the value of carbon dioxide, bicarbonate will rise by more than 1 to compensate for whatever extra protons that are being created. But once a person goes into chronic, then this process becomes more efficient. Now the kidney will say, okay, bro, I'll help you further. So in chronic respiratory acidosis, what will happen is that for every 10-point rise of carbon dioxide, the bicarbonate values will be rising even further. The rise would be about 4 milliequivalents. So as you can see, the process of compensation by the body has become relatively more efficient, which is why you can see that in acute, it was only a 1-point increase, but now it's a 4-point increase. And this is what he's asking in a question, that how do you differentiate acute from chronic respiratory acidosis? It is not CO2 values. It is the increase in the bicarbonate value, the compensatory process which is working, which is why the answer to this question is option number C. Unlike the previous question, which was having a bit of calculations, a bit of logic, this is pure mathematical data that we have discussed earlier. The 10 is to 1 rule for acute compensation with respect to respiratory acidosis. I mean, you are aware that the compensation of respiratory acidosis would be metabolic alkalosis, which is why bicarbonate is rising. I mean, the kidney is like a big brother. No, he says, okay, buddy, you have a problem. You're having problem of protons. I bring you bicarbonate. Bicarbonate will neutralize the protons. Then the kidney is saying, okay, I give you more bicarbonate because the process gradually will become much more efficient. And that is why this 10 is to 1 and 10 is to 4 rule is to be remembered. And that makes the answer to this question relatively easier to solve. The correct answer to this one is increase bicarbonate values. Coming to the next one, he says a 45-year-old man is brought to the emergency room in an unconscious state from Mount Everest base camp. There is no signs of any physical injury to the body and the ABG report of the patient is shown. And you can notice that the pH of patient is 7.31, so there is an acidosis. Now, acidosis can be due to respiratory problem for which PCO2 should be more than 45. Here it is 33, so it cannot be respiratory problem. Therefore, I'm just putting a line over it to say this is not a respiratory problem, but yeah, bicarbonate is lesser. Normal is 20 to 26. So the interpretation is the primary problem of this mountaineer is metabolic acidosis. Now I will be calculating the anion gap of this chap. Make it a habit. In fact, every time you see sodium potassium chloride given, no, just do this quick calculation, which is that you would be adding the value of chloride and bicarbonate, which is 18, and you can see this would be 135 minus 128. This would be 7, and therefore I can say the anion gap is normal. Since our patient is having normal anion gap metabolic acidosis, therefore our interpretation is NAGMA. It is a case of NAGMA. And then he says which of the following fits into NAGMA. Let's consider option number 1, which makes sense because if you are at a Mount Everest base camp, it's gonna be freezing cold. The mountaineer is gonna possibly, he maybe did not use proper thermals, he did not have proper gear, he did not have a proper quality tent. He could have ended up with primary accidental hypothermia. Happens with a lot of people who go there without experience. But then if it is hypothermia, then in every case of hypothermia, the cardiac output will fall. If there would be decrease in cardiac output, there would be decreased perfusion of the tissues per se, and therefore the cells will switch it to anaerobic mode of respiration. And when cells do not get oxygen, they start producing lactate. There would be lactic acid generation, and therefore lactic acidosis will occur. And you're aware from the cult mnemonic that lactic acidosis is an example of high anion gap metabolic acidosis. I can rule out two options in this question. Secondary hypothermia. Secondary hypothermia means that person would be having systemic disease. So option number D, I don't need to get into logic of hypothermia. I can say secondary hypothermia can occur with respect to conditions like myxedema coma. You know, if there's very severe hypothyroidism, we read myxedema coma, or there could be sepsis, which is very severe, causing hypothermia. So if somebody is having systemic disease and then there is hypothermia, we call it secondary. At Mount Everest base camp, it is mostly going to be primary accidental hypothermia, but again, that's an example of HAGMA. So two options are out, and I think now the answer is very, very clear. Diabetic ketoacidosis is again an example of ketoacidosis, right? For HAGMA, I told you a mnemonic, no? In the earlier part of the video's cult, that is ketoacidosis, uremia, lactic acidosis, toxins. So the only answer for this one would be diarrhea. I mean, there's a possibility that this guy at the base camp, maybe he did not maintain his hygiene, and when he ate food he could have got infected, and that's when he had diarrhea. There's no medical care provided there, so he kept on getting dehydrated and then was brought to the hospital. The main interpretation or the main deduction from this MCQ is every time you get a question on a metabolic acidosis, you have to think in terms of one, whether there is a compensation happening or not, and second, what is the anion gap. Here, while discussing this question before you, I did another mathematical calculation, which I did not say, but I'm going to say at the moment, which is that I subconsciously also did this activity. That is, I'm going to write it and erase it, that to this mathematical value of 18, I added 15. Remember, we calculated that expected PCO2 value. If you add 18 to 15, the value will turn out to be 33. So the actual PCO2 of the patient, this is the actual PCO2 is 33. the actual PCO2 is matching with the expected PCO2. I mean, this formula is to calculate the expected PCO2 because both are matching actual and expected. This means it is compensation. So the guy was able to compensate, that is okay, because there was no other secondary problem in this jab. But suppose the same diarrhea patient subsequently had dangerous hypokalemia, and his body was not able to compensate, his diaphragm was not able to compensate, then he could be having a mixed disorder as well. So this discussion, one, you need to interpret metabolic acidosis. You subconsciously need to add 15 to the whatever is the value of bicarbonate to check out whether compensation is occurring or not. Yes, this is compensation. This is partially compensated metabolic acidosis. The kidney, every time there's a metabolic acidosis, it's the lungs who are supposed to respond. If kidney has a problem, lungs will help. If lungs have a problem, kidney will help. Like kidney and lungs are like two, brother, sister, or two brothers, two buddies, which are always ready to help each other. Here, every time you have metabolic acidosis, the body will try to compensate by causing hyperventilation, and to calculate that whether there is a compensation, always use that formula. So this is partially compensated metabolic acidosis, plus there is a normal anion gap which has been determined. And considering that this is a normal anion gap, I'll just write that in capital on the mathematical perspective. I mean, every time they give you an anion gap, no, never take into consideration potassium values. I'm saying that once again, guys. I have seen people making that silly mistake of adding potassium to the positive charges. It's a nagma, and the first example for nagma is diarrhea followed by renal tubular acidosis. There is fistula and uretrosigmoidostomy. The correct answer to this one is option number B. Coming to the next question, we'll put a more pressure on the brain because there are 4 reports that are given. So let's start with the first one. pH is 7.5. So I can say that for the first report of 7.5, there is alkalosis occurring in this chap. Now, alkalosis can be due to respiratory problem or can be due to metabolic problem. In respiratory alkalosis, PCO2 should be less. This cannot be respiratory because PCO2 is rather elevated. I mean, every time you have elevated PCO2, that means there should be acidosis developing. So this cannot be a respiratory acidosis. It has to be a metabolic alkalosis because you can see bicarbonate of this patient is elevated. In fact, in this report, because all the 3 arrows are going in up direction, this means the fact that this guy is having metabolic alkalosis, which narrows down to option number D for question number 1. And let me now do mathematics also. That is 36 plus 15. If I add 36 plus 15, it turns out to be about 51. So compensation process is also working, because the expected PCO2 is matching with whatever is the actual PCO2 given in a question. So there is a respiratory compensation also. So 1D makes sense. I mean, there's only one option with 1D, but to be sure, let's do a quick evaluation for option number 2 as well. In option number 2, you can notice that there is an acidosis present, and for acidosis, either CO2 should be elevated for respiratory or bicarbonate should be less. In this question, CO2 is not elevated. It's rather on the lesser side, but yep, bicarbonate value is less. So this tells me it is metabolic acidosis. So I'm searching for metabolic acidosis in the options here, and I can pick up only one. That would be option number C. So these two combination does not fit in anywhere else, and I don't need to focus on 3 and 4. I mean, we can do it mathematically, but like in an exam situation, this question was mainly put to simulate a situation where don't expect that they'll expect you to solve one ABG question in 40 seconds or 1 minute, whatever is the duration. They keep on changing with the durations every time. So saying about in a 1 minute, traditionally we anticipate one question on ABG would be asked, and we try to do 4, but I try to make it easier for you by investing, like I would say, 30 seconds into 1 and 2 only, which makes it easier on the basis of permutation combinations which are given here. The subsequent one says the pH of the patient is 7.5, that is alkalosis, and then the bicarbonate values are elevated. So I'm thinking in terms of this could be a metabolic alkalosis. And why I'm not saying that this is a respiratory alkalosis is because for respiratory alkalosis, there would be carbon dioxide washout and CO2 should be less. Whereas in this person, what you're noticing is that at the moment, the PCO2 values are normal. So first deduction is that there is a metabolic alkalosis. I'm not going into whether there's a compensation happening or not. All I'm deducing is at the moment that my patient is having metabolic alkalosis on the basis of this report. It is uncompensated at the moment. Why I'm saying uncompensated? Because PCO2 is normal, and I can try and calculate the anion gap in this patient also mathematically. This would be 130 minus 90 plus 30. That would be about 10. So just let me write down the value of 10 and then consider the 4 options. Weakening of respiratory muscles effort due to neuromuscular disease. I mean, every time respiratory muscles will not function properly, carbon dioxide would not be kicked out. That should cause respiratory acidosis, and our patient is having alkalosis, so he is unlikely. Methanol causes, that's huge tragedy. It again causes metabolic acidosis. And this does not fit our discussion. Methanol will cause formaldehyde, formic acid, as I've explained in the earlier videos. So this cannot be methanol. We're left with panic attacks versus vomiting, and panic attack will cause hyperventilation. It will cause respiratory alkalosis, and respiratory alkalosis should be having CO2 to be lesser, whereas in this question it is normal. So even by exclusion, you are able to work out the deduction. That would be vomiting is the plausible explanation for this ABG report. Coming to the next case, here one pointer is that he's deliberately mentioning the pH towards the end because we'll waste our time reading the initial values. Every time you give an ABG report, no, always first look at pH, then look at PCO2, then look at bicarbonate. The data will be given in a jumbled format. They can give you a long printout, image of a printout of a report, and the data could be deliberately given jumbled. And if you invest our time looking into sodium, potassium, bicarbonate values, I can lose a precious second. So that would be my suggestion. Anytime ABG related question is given, always scan the pH, and the moment you are looking at pH, do this activity immediately that okay, it is acidosis. And if it is acidosis, then if PCO2 is elevated, I'll call it respiratory. Here PCO2 is not elevated, rather it is lesser than normal, but at the same time the bicarbonate value is lesser. So my immediate deduction is that I'm dealing with a case of metabolic acidosis. Now, when I'm doing metabolic acidosis evaluation, I have to do two activities then. One would be to check for the compensation part. So you just need to add 15. And what you can see in this case is that the bicarbonate value is 9. And to that, if you add 15, that will work out to a value of about 24. This is the expected PCO2 of the patient. And you can see that the expected PCO2 and the actual PCO2 are both matching. The actual PCO2 is 24 and the expected is, though honestly in my mind I was anticipating while solving this question that the two would not be matching. It might be a mixed possibility, but luckily for me values are matching, so it is compensation which is occurring. He says what is the work, what is the possibility? So let's do the next step also, calculation of the anion gap. If I do anion gap calculation, that's gonna be 135, and from that I'll be subtracting 116 plus the value of bicarbonate. That would work out to a value of 10. 10 is a normal value. So my final deduction for this case is that this chap is having, let's work out the possibilities. It cannot be metabolic alkalosis from the pH. High anion gap metabolic acidosis, you've done the calculation in this case, is turning out to be 10. So that would not be the answer. Respiratory acidosis can be ruled out because PCO2 is not more than 45 millimeter of mercury. So that leaves us with only one. That would be NAGMA. Coming to the next question, he says in the given acid-base normogram diagram, comment on areas marked as A and D. So one, you will notice that this question is from physiology. In fact, this is integrated physiology. And this diagram is given in Gelong also. It is called as Davenport diagram, where on the x-axis you can see the pH of the blood. On the y-axis there is bicarbonate, and then I'm writing y-axis once again because on the right hand side you can see there is carbon dioxide values given as 10, 15, 20 going up to 40, and once they're going more than 40 they're spilling over onto the horizontal side. So I can call this a z-axis as well. At the moment, the message is in Davenport diagram, we are going to be evaluating data with respect to this midline. That is, if I move towards the left side of 7.4, where my arrow is going, I'll say person is going towards acidosis. If I move to the contralateral side, where the arrow is pointed towards green, towards 7.5, 7.6, I'm going towards alkalosis. Now on the red side, I want you to focus very carefully. You see, if I look at point number F will be having on the x-axis acidosis, you can see less than 7.3. Now I will be looking the data for bicarbonate also. You can see the way I'm doing the marking at the moment, bicarbonate values are also very low. That means it is pointing towards metabolic acidosis. The third parameter of metabolic acidosis is that PCO2 is also lower, and you can see that horizontally on the YZ axis even PCO2 is less. So you look at the intersection here, you're checking at bicarb, you are checking at PCO2 less, and pH is also less than what should be, average. So therefore this, that is point number F that is marked in this particular diagram, would be answered by you as metabolic acidosis. And now once you've done this marking for metabolic acidosis, we will move up in this loop and focus on point number A, which has been the subject of this question. Again, I want you to look at the yellow marker. A is on the x-axis pointing towards acidosis. So far so good. Now you need to focus on that this point A is intersecting with very high value of carbon dioxide also. Look at this vertical yellow line that I've created. You can see there is acidotic pH on the x-axis, And if you go up PCO2 70, so if pH is less than PCO2 is also ultra high, it means it is respiratory acidosis. And along with that, at the moment, you can also see that the bicarb is between 24 to 28, because bicarb is between 24 to 28. That means compensation has not started, and therefore point number A, which has been asked in this MCQ, would be answered by you as acute respiratory acidosis. I'll give the logic for acute respiratory acidosis once again, which is that if you scroll through the data with yellow line, A is pointing towards acidosis. When you look at vertically, you can see there is very high PCO2, plus you are checking out that there is also going to be normal PCO, normal bicarbonate, so compensation has not started. But if compensation will start and bicarbonate will start rising, that point number B would indicate that compensation process is working, and therefore point number B would be answered as chronic respiratory acidosis. At the moment, I want you to understand that in Davenport diagram, there will be total of 6 interpretations, out of which 3 I have told you. If you move towards the left side of this baseline, then inferiorly is metabolic acidosis. Above that, the loop that you can see is acute respiratory acidosis, and above that is chronic. Why above? Because bicarbonate will begin to rise for compensation purposes. Loop number C is metabolic alkalosis. So let's do logic once again. That would be in the following sense. Again, the marker to be pointed upon, you can see there is a pH which is elevated, so alkalosis. Then you can see that bicarbonate is also elevated and PCO2 is also elevated. So if these focus on the intersection here of the yellow marking. If you focus on the intersection, you can see that pH is also elevated, PCO2 is also elevated, and bicarb is also elevated. So it is metabolic alkalosis. And then loop number D, which is asked, is using the same logic. It is acute respiratory alkalosis. And the next loop where the bicarbonate value will begin to fall, the loop number E that is described is chronic respiratory alkalosis. So a bit of effort to be done by you to remember this data. First, try to remember the data for the acidotic side. Start from the bottom. Metabolic acidosis, acute onset respiratory acidosis. First acute word is coming, then chronic respiratory acidosis is coming. When you move on to the right hand side, mentally try to visualize with me. The arm would be metabolic alkalosis. Then would be again acute word coming up first, then the chronic word coming up. So you just need to practice the 6 arms of this normogram, and the answer to our question would be acute onset acute onset respiratory acidosis with the acute onset respiratory alkalosis. So the correct answer for this one would be option number C. Option number B that I mentioned would be for C, reflection here. It is that he said per se marked area A and marked area D. So you can understand a bit of concentration would, in fact, lots of concentration would be required to solve this question with respect to, because these markings would also be given and they'll not be corresponding to the options. I hope you made a point or you understood that point. The markings are also given in ABCD and the options are also given in ABCD. So they can be a bit of concentration lab. Know that even if you work out these loops, it might still cause an issue. So try working out by yourself by making a fan like this. There would be 6 blades of this fan. The 3 blades are to be answered in the sequence. On the left side of the midline as acidosis, obviously. On the right hand side as alkalosis. And if you practice these 6 blades of a fan, you'll be able to work out what's called as Davenport diagram. And this helps in this is mainly for use by nurses or by non-medical people. Paramedical people who would be working with you. Like in USA, you have a physician assistant. You would be having people who work in as anesthesia assistant. So, in America, you are having a lot of paramedical staff with you. So they would be the ones who will be using this Davenport diagram, and you as a doctor obviously do not need any of this and you can do calculations in your mind. But I thought that I should incorporate one such question before you from integrated renal physiology as well. Having said that, let's focus on the next question, which said that a 40-year-old man presented with nausea, dizziness, and hyperventilation. ABG analysis and electrolyte levels revealed metabolic acidosis with normal anion gap. So he's giving me NAGMA and he's saying what is the possible reason for it. So this is much more easier a question. I was anticipating while reading it, it would be some trick. But then I have to just pick up a cause of normal anion gap metabolic acidosis. The mnemonic is Dr. Fuse. So the answer is very clear. Lactic acidosis is HAGMA. Renal failure is HAGMA. Methanol toxicity is HAGMA. That would be solved on the basis of cult mnemonic. That is ketoacidosis, uremia, lactic acidosis, and toxins. But renal tubular acidosis of all the 3 varieties, whether it is RTA1 or RTA2 or RTA4, they all fit into what we discussed at the moment. That would be NAGMA. So renal tubular acidosis would be the answer for this particular question. Let's look at the next one. He says, which of the following is not associated with type A lactic acidosis? Lactic acidosis is of three varieties. Type A is the one where there is going to be a perfusion issue, or there is going to be severe hypoxia present, that the cells are not getting sufficient amount of oxygen, and as a result of it, lactic acid will be produced. So somebody is having COVID-19, myocarditis and cardiogenic shock. The word shock is telling me that perfusion will be less, and therefore it is type A lactic acidosis. Septic shock, again, due to pyelonephritis, is again perfusion of tissues would be less. Cyanide toxicity will cause amount of hemoglobin to be available to be lesser, because this is histotoxic hypoxia. So the total amount of oxyhemoglobin, because cyanide toxicity will damage the mitochondria, the electron transport chain will be hampered, cytochrome oxidase. So therefore, if the powerhouse of the powerhouse of the cell, which is mitochondria, will shut down, so there is bound to be energy depletion. Energy depletion will deplete availability of oxygen, and therefore oxyhemoglobin is less, will also cause type A lactic acidosis. But drugs like metformin, fenformin, they are all causes of type B lactic acidosis. So the question is saying not associated with. Then A, B, C are associated with type A lactic acidosis, and metformin or diabetes mellitus per se, or renal failure, or fenformin are examples of type B lactic acidosis. Next up is a question that talks about a hepatitis B patient with liver cirrhosis and massive ascites, that is explaining the breathing difficulty because diaphragmatic excursion would be hampered, and he's on spironolactone plus Lasix for management of this ascites, that is diuretics are being used, and we are forced to use Lasix also because he's probably not responding to spironolactone alone. The ABG shows pH of 7.55, so there is alkalosis present, and alkalosis has two reasons: respiratory or metabolic. If it is respiratory, the PCO2 should be less than normal. In this case, you can see the PCO2 of the patient is normal. It is not less, so it is unlikely to be a respiratory etiology. But bicarbonate of this patient is elevated. Normal is 22 to 26. Here it is elevated, going up to 33. That would be a metabolic alkalosis as a final deduction. Now, for every case of metabolic alkalosis also, you are supposed to calculate the expected PCO2 and match it with the actual PCO2. And therefore, in all questions of metabolic acidosis and metabolic alkalosis, the learning for you in this last question is that for all cases of metabolic acidosis and metabolic alkalosis, always check out and make a comparison between the value of the actual PCO2 and the expected PCO2. As you can see, bicarbonate value is about 33. If I add 15 to this, the expected value should be 48 millimeters of mercury. But what is the actual PCO2? Only 38. At the moment, what I can say is that because of the fact that the two values are not matching, that means it is not compensation. This means it is a mixed disorder. And when I say mixed disorder, this means that this person is having respiratory alkalosis with metabolic alkalosis. I'll give the reason for the same also from the clinical perspective, but the mathematical deduction is that because both the values are not matching the actual PCO2 and the expected PCO2, that is why I said that this is not compensation. If the values were matching, I would have seen compensation. And now once I worked out the mixed values, then let's look at it from the clinical perspective. Why is there a metabolic alkalosis in this patient? Well, there are two reasons for it. One reason for metabolic alkalosis is anybody on diuretics. Side effect of diuretics is always metabolic alkalosis because it causes a volume depletion. The second reason for this would be ascites. And if you've forgotten it, let me do a quick evaluation before you. Whether it is diuretics or whether it is third space loss. Ascites is redistribution of fluid in the peritoneal cavity now. So it is third space loss which is causing dehydration. Because of dehydration, the GFR will be less. If GFR is less, the RAS will be activated. And now let's look at how aldosterone will work, because one of the basic functions of aldosterone is gain of salt and water. Because in this person, the body is trying to upgrade the RAS system. Therefore, salt and water gain will be occurring, which is why we tell ascites patients not to take salt or avoid added salt to the food. There's a second problem in these patients, that would be urinary loss of not only potassium but hydrogen. At the moment, I'm not focusing on potassium, I'm focusing on urinary loss of hydrogen, which will be more than normal, and that will explain metabolic alkalosis. Guys, diuretics cause dehydration. in excess usage, and ascites also causes dehydration. In a sense, it is third space loss. There is redistribution of fluid. The fluid should be in the blood vessels. It is going to be present in the third space, so blood supply to kidney is lesser, which is why urinary loss of hydrogen will occur. That explains metabolic alkalosis for these patients. And well, what explains respiratory alkalosis? I can say because he's having shortness of breath. Anybody having shortness of breath will do hyperventilation. Hyperventilation will cause a carbon dioxide washout from the body of this person, and that explains why this guy could be having two types of alkalosis. So in question number 1, I taught you a patient having two types of acidosis, respiratory and metabolic. In this example, I gave you a patient who's having two types of alkalosis, metabolic as well as respiratory alkalosis. And finally, I can say I gave an example where there was combination of metabolic acidosis and metabolic alkalosis, that was CKD with uremia. Let's do a quick recap here for these various permutation combinations. If we are having both metabolic acidosis and respiratory acidosis, the simplest example could be pulmonary edema and congestive heart failure, where low cardiac output will explain underperfusion of tissues and metabolic acidosis, and pulmonary edema will explain why carbon dioxide from the body cannot be excreted. Similarly, if there is a person who's having a pneumonia, then pneumonia will be causing fluid in the alveoli, and therefore as a result of it, this chap will be having buildup of carbon dioxide in the late stages. And because pneumonia is an infection, person can go into septic shock, and septic shock will cause metabolic acidosis. So given two examples. For metabolic alkalosis of two different varieties coexisting in a single patient, the usual example that will be given in a question would be a case of cirrhosis, which was discussed in the previous case, and this guy would be simultaneously on diuretics as well. The cirrhotic patient will develop massive ascites, which is going to explain the breathing difficulty which is experienced by these patients. The scenario where you will be getting a combination of metabolic acidosis and metabolic alkalosis would be renal failure patient, and this chap is also having now development of uremia, which is causing vomiting. He might be having edema also. For edema, we might be using diuretics. Usually the diuretic that is used in CKD is thiazides, and biggest side effect of thiazides apart from hypokalemia and hypomagnesemia is metabolic alkalosis. And then lastly, you can be having, this was I think the most surprising one, combination of hagma and nagma in a single patient. This could be glue sniffing, that is toluene toxicity, that is documented. And then another example where we could be having a combination of this could be like a person having diarrhea and at the same time is also having lactic acidosis as well. So if diarrhea is there, there is normal NN gap, and lactic acidosis could be present because of subsequently under perfusion of the tissues. And the same case of diarrhea, when he goes into severe dehydration, can then start developing high NN gap metabolic acidosis as well. So these are a couple of details, guys, which I would like you to remember for as a summary that I've explained. In this particular video, I've tried to focus on these peculiar permutation combinations, and I've tried to give not only the mathematical reasoning. If I gave mathematical reasoning, this video would have been much more shorter, but I have tried to incorporate both the mathematical reasonings as well as the clinical scenarios, which will make it easier for you to remember these permutation combinations. So keep the pressure on, keep hammering, and you are doing the right thing by learning ABG, because that's going to be critical for you as functioning in the ward.